we're increasingly working outside the health space in the broader education, housing, transportation, and other sectors. And the more that we worked on this topic, the more that we realized it had broad applicability across the range of policy domains that we're interested in, which is why we've used the framing health and social systems here. And throughout the slides, I'm going to keep coming back to that point, but sometimes I'm going to give examples drawn from the Ontario health system simply to make a point. So these are my top 10 messages. I'm going to go through them one by one, and then I'll come back to them at the end. I have messages related to why we might want to use this framework, to the fact that any effort in this area needs to be operationalized locally. Locally, in the case of the work we did, happened to be at the level of a province in the one instance, but also at the level of a region, at the level of a broad category of conditions, mental health and addictions. So locally will mean different things to different people. I'll also talk about a definition that starts with what I've called here clients. For the work we did in Ontario, the focus was patients, broadly defined, but because I'm speaking across health and social systems, I'll use the more generic clients. Fourth message is about the nuances in the 7 characteristics of rapid learning systems mattering. So we spent a lot of time speaking to a lot of people to try to get the nuances right. So we carefully chose words that, at least in the context with which we're familiar, seem to be the right ones. The 5th message has to do with documenting assets and gaps. This is work that can be done relatively quickly. So in Ontario, we documented them in 4 areas over about a 6-week period. Obviously not working full time. This was amidst a lot of other activities that were going on. Message 6 is about the need for this documentation to be iterative, systematically going into new areas, finding out what's happening, where the gaps are, trying to address the gaps, join up what's already happening, but it needs to be iterative. 7 and 8 have to do with windows of opportunity, that the chance to really advance our efforts to create rapid learning health and social systems needs to be sensitive to the fact that both health and social systems operate within political systems, and we have to make the case for top-level politicians, policymakers, health system leaders to embrace this, and that means being attentive to windows of opportunity. And then 9 and 10 are really about being clear about the roles, and also about the fact that if we're really going to move forward in this area, while learning collaboratives are typically talked about in the context of particular initiatives to move the dial on a particular topic, we actually also need learning collaboratives operating at the level of the entire rapid learning system. And I'm going to come back to that at the end. So those are the 10 messages, and I'm going to go through them one by one. So the first message is about why to do this. So, in the last decade, I cannot think of another example of a framework that got me as excited as the Rapid Learning Health Systems framework. It was the first time that I found a language that had the potential to open up conversations with colleagues working in the data analytics space, in the implementation science space, in the evidence-informed policy space. And I think the reasons for getting excited about it, I've laid out here in the 3 bullets. One is I think it has the potential to drive transformations at all levels of a system in ways that are more rapid, better sustained locally, and more widely spread. And one of the recurring themes in the presentation is going to be across levels. So here I've highlighted a few: teams, programs, organizations, and districts or regions. And another way of saying this is rapid learning systems as a framework offers the potential to help us join up the different parts of the system so they work well together. Second piece, now turning to the research system. In my view, this kind of framework can motivate greater collaboration among and enable greater impacts of all elements of the research system. And then finally, if we think of the quality improvement infrastructure sitting in between those, in some jurisdictions, that's going to have a different label. I'll use the term quality improvement, but it's the folks who are working at the interface between the health system and, in a way, the data and research system to try and drive improvements in the system. So call it what you want in your own country, your own province, your own system. I've called it here quality improvement infrastructure, and my view is this kind of framework can help us better leverage that infrastructure and then help it act as a better interface between the health and social system and the research system. So message one was, I think this framework has the tremendous potential to get us farther, faster together. The next slide is just expanding a little bit on one of my points, that to me this framework offers the potential to get us talking across silos. So I sit in typically the second to last row of this table. Our focus is how do we support evidence-informed policymaking? And we're typically doing it in the space of asking, how do we strengthen health and social systems by improving the governance, financial, and delivery arrangements in the system? But when we're working up a problem, we find it hugely helpful to speak to the data analytics people. When we're thinking about which policy or program options, we often find very powerful insights coming from our peers working in the guidelines and technology assessment space. And when we want to know what those options might look like if they were rolled out across the system, we find our modeling colleagues particularly helpful. And when we think about the implementation piece of any given initiative, we find our implementation science colleagues particularly helpful. And then when we come to monitoring and evaluation, we find working with experts in evaluation to be very powerful. My experience is in many countries, in many Canadian provinces and territories, these groups work in silos. And for me, the rapid learning system framework offers the potential for all of us to see how we can contribute to driving improvements in the system. So now on to message two. So message two is that the framework needs to be operationalized and assets and gaps documented locally. And I mentioned at the beginning that our first effort at this was focused on the province of Ontario, and within that, in a couple of different spaces, which I'll come to shortly. But we also wanted to operationalize the language and the concepts for a Canadian context. If you're in another country, like I saw Andrea Yearwood from Trinidad and Tobago in the list of participants, different language might work. And so I think this effort to make sure that the words that we use to describe the framework and to think about how we operationalize it have to fit within whatever that local environment is. So the rest of the text on this slide is just to give you a feel for the steps that we took to operationalize the framework and to document assets and gaps. So first, we did a rapid synthesis of the existing evidence to understand what's known about rapid learning systems. Quick takeaways here, largely a US-centered literature with the framings, the organizational as opposed to a system focus, and word usage that makes sense for a US context, but didn't translate often well to our environment. And interestingly, a big focus on the ethics of conducting rapid research in health environments and what pieces need to go through ethics and how ethical issues are addressed. One of the striking things for us from the literature was the lack of recognition of the complementarities among timely data, rapid primary research, and rapid syntheses of existing evidence. So the US literature to us was very dominated by data, much to some extent by rapid research, but only a particular type of research, randomized trials, which answers questions about benefits and harms, but not the full range of questions that need to be answered, and virtually no attention to syntheses of what we already know. No country, even the United States, can have all the primary research that it needs for a fulsome workup of a problem, options, and implementation considerations. We also used a couple of sources to force ourselves to think broadly about assets and gaps, and I give two examples here. We also conducted a number of key informant interviews. So we put draft asset and gap maps in front of people and said, what are we missing? or what have we got wrong. We found this very helpful to identify assets, less helpful for gaps. And we found a tremendous amount of enthusiasm. I cannot think of a similar set of interviews, despite how often we use this approach, where people were so excited by the potential. I will be honest, though, the only time that we heard skepticism was from patients. And their experience, at least in the Ontario health system, that change comes so slowly that the word rapid is an oxymoron. So we jokingly said that we would call the report the less than glacial learning health system. So if the current system is only moving at a glacial pace, surely we can do better than that, but hopefully one day we can get to rapid. For the key informants who we couldn't get on the phone, we sent them our draft tables, and that was a way for them to very efficiently provide input. So those are some steps we found helpful in operationalizing both the framework and documenting the assets and gaps locally. So if I now move on to message 3. Message 3 was the definition needs to start with clients and cover all levels. So you'll see in the first bullet point, a rapid learning system needs to be anchored on client needs, perspectives, and aspirations. And some of you will recognize the triple aim language. It should be focused on improving their service experiences and their health and well-being at manageable per capita costs and with positive provider experiences. So the latter taking us into what's sometimes called the quadruple aim. At a recent meeting at the Ontario HIV Treatment Network, I gave the example of a goal for a rapid learning effort could be, for example, to achieve judgment-free active offer of pre-exposure prophylaxis to people at high risk of HIV. So these types of goals that can be achieved from rapid learning can also be these more experiential goals. To me, it's perfectly reasonable to set a standard that people be actively offered pre-exposure prophylaxis and not be judged in any way during that clinical encounter. So that would be an example of anchoring a particular initiative on client needs, expectations, or aspirations. Second part of the definition is it's driven by timely data and evidence. Third, supported by appropriate decision supports and aligned governance, financial, and delivery arrangements. And fourth, it's enabled with a culture of and competencies for rapid learning and improvement. And in the first line, you'll see my point about all levels. So from the level of the individual, from a self-management or self-care perspective, up to the professional encounter level, up to the program level, up to the organization, up to the district or region, and then finally at the level of the system overall or the government. So rapid learning can happen, in my view, at all of those levels, and a rapid learning system needs to actively support that learning at all of those levels. At the bottom, you'll see what I've called here a broad definition of clients for the work that we did for Ontario. We used the language of patients broadly defined, but here I've said clients. So that was message 3. Message 4 is that the nuances in the 7 characteristics of a rapid learning system matter. So on the previous slide with the definition, I had 4 bullets. So here there are 4 categories of characteristics. But within that, when you count across the categories, there are 7 characteristics. So I won't repeat the first one because I covered that because it's so important on the previous slide. But when I come to data, the language that we used was that the system has to capture, link, and share, and it needs to share that data with individuals at all levels, data about client experiences, alongside data about other process indicators and outcome indicators. And the experiential data needs to be both about the services people receive, but also about their transitions across services and their experiences over time. And then I give some examples of process and outcome indicators. So in many health systems, we collect a lot of process indicators. We often collect outcome indicators, but not in ways that allow us to tie them back to interventions that we're undertaking. And where we probably are the weakest is collecting the experiential data. But rapid learning health systems give very significant attention to that experiential data. Characteristic 3 is the timely production of research evidence. So a good rapid learning system would have mechanisms to produce, synthesize, curate, and share, again, with individuals at all levels, research about problems, research about how to do better, and research about how to implement whatever course of action is selected. So we sometimes do very good getting reports out about problems in the system. Sometimes we do well getting reviews out about the effects of options, but we don't do a very good job of bundling all of those together. So if I go back to my example of pre-exposure prophylaxis, in one document for a particular context, what do we know about the current situation and the drivers of that? What are the options for doing better? And then how are we going to implement a preferred course of action in a very iterative way over time as we look to see whether we're moving the dial on the outcomes that we said mattered. If I now move on to characteristic 4, appropriate decision support. So the systems need to support evidence-informed decision-making at all levels with appropriate data, evidence, and decision-making frameworks. Data and evidence on their own aren't enough. We need to help people with simple frameworks to understand how we can better think through problems and their causes, different ways forward or different options, different approaches to implementation. Characteristic 5 is we need aligned governance, financial, and delivery arrangements. So governance arrangements being things like decisions. So an example would be how we make decisions about joint learning priorities. So how in the mental health and addiction sector or the housing sector do we decide where are the areas where we want to move the dial? Financial arrangements would be how money flows. Delivery arrangement would be how the system is organized to get services to the people who need them. Characteristic 6 is about culture. So the system ideally would be stewarded at all levels by leaders committed to a culture of teamwork, collaboration, and adaptability. Those are 3 distinct areas. Sometimes we do well with one of them, less frequently with 2, and probably quite rarely on 3, but all of them are a key part of culture. And then moving to 7. There we go. The last one is about competencies. So systems are rapidly improved by teams, again, at all levels, who have the competencies needed to, and now there's a long list, to characterize problems, design approaches, implement the approaches, monitor their implementation, evaluate their impact, make further adjustments as needed, sustain proven approaches locally, and support their spread widely. So again, this is where nuances matter. This isn't just an issue of using data and evidence to understand problems. It's about trying to make a difference in people's lives and constantly trying to up our game, and where we find things work, scaling them up. Where we don't find them work, then go back to the drawing board and try different approaches. So this is where the competencies come in. So that was message 4, probably the longest message that I have. Message 5, I'm not going to go into detail on the table. It spans 2 pages. I'm just showing it to you more to illustrate that documenting assets and gaps isn't rocket science. So when we are asked to undertake this work by the Government of Ontario, the jurisdiction was already chosen for us. So we were working with the province of Ontario that has some excellent things already happening in this space, like the Ontario Spore Support Unit, which for the first time in my 20 years in the province is acting as a centripetal force, forcing the different research groups to have to work together because we all bring partial solutions to the table. There's probably other provinces, but I saw Tom Noseworthy on the list of participants. We know that BC is actively working in this space, and hopefully there are other provinces. So for us, the province was selected, and we looked at what were the assets and gaps at the level of the entire province. Then our province is divided up into 14 districts. So we have an unfortunate acronym, Local Health Integration Network, but think of these as district health bodies. We picked one of the 14. We picked the one that was further ahead, that what we had heard was doing particularly innovative work, in part because of Rob Reed coming back up from the US and beginning with very strong leadership at the senior executive level to really advance the work on a rapid learning system within that particular region. We didn't hear in the course of our interviews about other regions that were doing similar work. So in this case, we ended up focusing on a region that was probably a bit more advanced, or what is more advanced than the others. Then when it came to sectors, we decided to pick one. We picked primary care. We probably could have been like the drunk looking under the lamppost for his or her keys. The easy place to look would have been in specialty care, hospitals, where some of this thinking has been around for a while, and Ontario has a program called Arctic that uses some of this thinking. But most health systems these days are struggling with how to improve home and community care and primary care, so we zeroed in on primary care, where we saw some nascent work being done by very talented people by Merrick Shorenstein, but otherwise not a lot of activity with a rapid learning systems orientation. Now if I move to the next slide, we also decided to pick a category of condition. Now, of course, we're talking about people here. So these are people living with. We ended up picking mental health and addictions. In this case, we didn't pick a category of conditions that was further along. Had we done that, we probably would have picked cancer, which had already started to move in this direction with Cancer Care Ontario. But we picked another system or a sector that is a bit separate from the rest of the system. And again, saw lots of kind of potential there, but not a lot of things that are labeled this way or that are organized in this way. We did not pick any categories of treatment or health determinants. We could have asked, do we have a rapid learning system when it comes to prescription drugs and appropriate prescribing? We could have asked, do we have an optimal system for our Francophone populations in the province? But we did not get to that. So we focused on the province as a whole, one region that was further ahead, one category of conditions, and one sector. So that was how we did our initial asset and gap map. Now if I move on to message 6, message 6 is this type of process that we went through should be iterative. So it was a moment in time piece of work for us, but if that's all that happens, then this was probably a wasted effort. So this work needs to now be rolled out across other regions, across other sectors, across other prioritized categories of conditions. We need to be thinking this way from a treatment perspective, from a health determinants perspective, from a population perspective. And all the time that we do that, we need to keep coming back to the fact that this rapid learning system for Francophones, or this rapid learning housing system, or this rapid learning home and community care system operates at multiple levels, at the individual, the service encounter, the program, and the organization level. So again, these assessments need to be broadened, but they also need to be updated periodically. My hope would be, when we go back in 12 to 18 months, that other regions have moved a long way, that primary care has taken bold steps forward, that the mental health and addiction sector is going gangbusters. So that type of periodic check-in is key. And then maybe the key point is at the bottom of the slide, that a rapid learning system, if you think of that in the singular, it's almost certainly going to take the form of a great many interconnected rapid learning health and social domains or systems. So we would have it operating for HIV with a key organization like the Ontario HIV Treatment Network. We'd have it with mental health and addictions with a variety of key bodies trying to drive it. The system is not a single system. It's hopefully a set of interconnected rapid learning systems. So now I'll move on to 7, windows of opportunity. I mentioned before that whether or not we go down this path, a lot of that hinges on leaders. Some elected politicians, some top public servants, some the heads of hospitals, the head of regions, and so on. And windows of opportunity matter. There are times and places when our chance to really move down a path of rapid learning health systems or systems is higher, and times when it's lower. On this and the next slide, I've just given you some examples of windows of opportunity in the province of Ontario as they were a few months ago, just to get you thinking about, from the perspective of your country, your province, your sector, your population of interest, where are the windows of opportunity? So in Ontario, one of the key things are the emergence of these sub-regions, 70 plus of them. They create a natural focal point for rapid learning and improvement at the population level. So that's a huge opportunity to think about how do we support them to become 70 plus rapid learning regional systems. Second example would be LHIN, or Regional Health Authority Transformation Initiatives, which is one of the angles that we could go for, would be trying to convince hospital research institutes to see values in investing their research dollars in rapid learning and improvement, both in their hospital, but very importantly in their region. And this is something that we've seen that one region just west of Toronto, Mississauga, do because of leadership from a hospital system, Trillium Health Partners. On the research system side, you'll hear from Eddie in a moment. The Ontario Spore Support Unit, part of the National Patient-Oriented Research Strategy, is currently coming to the end of its first 5 years. I mentioned before, it's the most important centripetal force in our research system. It has tremendous potential to further those collaborations and better link up that research system with the quality improvement infrastructure and with the health system. So that renewal provides a hugely important opportunity to embed a rapid learning system orientation within all of the work of that SPORE support unit going forward. The final slide for message 7 in Ontario would be the existence of a government agency charged with supporting quality improvement, and that positions it well to create in-house mechanisms that support connections at multiple levels across the health system and the research system. So these are simply some examples from the Ontario health system to get you thinking about windows of opportunity in your country, in your province, in your region, wherever you sit. What are the windows of opportunity that have the potential to create the magic that would allow us to take steps towards a rapid learning system in the area that you work? The next slide is about the reality that windows of opportunity also sometimes close. There are sometimes times that are not good for introducing new ways of doing things or accelerating progress in areas of agreement. So one concern would be health and social system leaders make only one-time decisions that don't push the system down a path of increasingly becoming a rapid learning system. This isn't something that we make a major announcement about, wipe our hands and hope for the best and check in 3 years later. It needs active stewardship, probably over a decade or more, to fundamentally align the system in this direction. Second example, advocates for investments in data only. I know a lot of people who think the sun rises and sets on data. I think it's hugely important, but I think it's part of the solution. Advocates for rapid primary research, rapid trials, other types of research, very important, one piece of the puzzle. Investigator-driven research, very important in identifying new innovations that 30 years from now, 20 years from now, 15 years from now could transform the system. And yes, absolutely, we need it. But we need a balance among timely data, rapid primary research, and timely syntheses of existing research. And if the advocates for only one of those areas triumph, then we are not going to move towards rapid learning systems. And then the final concern would be quality improvement leaders seek to own the whole process. The more that I read about rapid learning health systems and social systems, the more I see the value in decentralized capacity for rapid learning and improvement. I'll come to the fact that we need coordination, but we need also decentralized competencies and cultures that are supportive of this. And now if I move on to message 9, roles need to be defined. So I just give you 2 examples of roles here. So one is, as I mentioned before, while decentralized competencies and culture are key, there's also a role for coordination. In some cases, this role might be played by government. If I go back to my HIV example, a key coordinating body could be the Ontario HIV Treatment Network. There are many examples I could point to in different sectors for different populations, for different conditions, and so on. But whoever is doing the coordinating needs to use the framework, incrementally join up the assets and fill the gaps, and periodically update the status of the assets and gaps at all of these levels. And I've given you some examples here drawn from the work that we did, but you could easily imagine translating them over into the world of housing, transportation, education, and so on, broader social systems. Another example of roles, and I won't get into this, but I just wanted to foreshadow Eddie's response. That one of the absolutely key roles from my perspective is the Ontario Spore Support Unit. So on the left-hand side of this table, you'll see the rapid learning health system characteristics. The way that the Ontario Spore Support Unit talks about its work is in the right-hand column. And one of the steps that Eddie, with some collaborators, is currently thinking through is how do we line these up? How do we line up how we think about how this critically important part of the infrastructure is, the Ontario Spore Support Unit, against the rapid learning system characteristics? And now on to lesson 10. And again, tables not meant to be looked at in detail. It's meant to illustrate a point. I mentioned at the beginning that learning collaboratives are key in rapid learning systems, but they're typically focused on moving the dial in a particular area. What I'm talking about here is a rapid learning collaborative about learning collaboratives. So how do we bring the key people together across a system who are championing the move towards rapid learning systems and get them working collaboratively together, sharing experiences, helping one another solve problems. So I've given some examples here of the types of people in Ontario who I think would be important to have around the table focused on a rapid learning health system. But depending on your area, it's going to look like a very different list. But I think we need to be collaborating and learning from one another. So these were my 10 messages. So as I mentioned before, the experience comes out of a particular jurisdiction, the province of Ontario, a particular area of focus, the health system. But given that we are increasingly working in the broader social system space, I am struck by how the concepts apply to that broader space. So those are my 10 messages. I won't go through them again. Just some acknowledgments. These are the people who helped us produce this work and the roles that they play, and we're very grateful to them. The next slide is about our own next steps. So the second bullet, any of you on the line from Canada who are interested in joining forces, especially as we move beyond health into the broader social systems space, we would love to have a conversation. What we know is that we now have funding from a U.S. foundation and a Canadian foundation to push forward a 13-country learning collaborative focused on the non-health sustainable development goals, and rapid learning systems is going to be front and center in our thinking as we undertake that 3-year program of work. If you're interested in reading more, the resource that we prepared is sitting on our website for free. So I've given you the URL. Maybe Steve can copy it and put it in the chat box. You can also just Google McMaster Forum Rapid Learning System, and it should come up right away. So that's freely available. And then we're on to questions. So, Steve, I'll turn it over to you. I'm not sure if there are any immediate questions. Otherwise, we can go to Eddie.
Thanks, John. We do have a couple of questions that have come through, but I think that what we'll do is maybe go to Eddie first for his response to your top 10 insights, and then come back to the questions.
Great. Thanks, Steve, and thank you, John, for being so comprehensive that I've had to come up with lots of new ideas of what to say. I'm assuming everybody can hear me okay?
Yeah, absolutely.
Yeah, we can hear you, Eddie.
Great, fantastic. So I wanted to touch on, not necessarily going through the slides, but sort of talking a bit about the experiences that I've seen and what we've seen at the Ontario Sports Support Unit, how that relates to the context that, John, you've laid out around what the opportunity in Ontario is, and also how we leverage some of the things that are happening elsewhere using the kind of opportunities that you're now moving into at the McMaster Health Forum and sort of driving this into other jurisdictions as well. So I think one of the key things in terms of my experiences that really resonates with what you've talked about, John, is the idea of this and maintaining the end goals in mind. So ensuring that this is a stakeholder-driven, stakeholder-related approach to learning. It's understanding that it's not just about the system, it's understanding that it's about the people that use the system as well. That's a particularly important component that I think is often overlooked in a lot of the US conversations around the learning health system, where it's really about the system itself that's trying to move forward rather than for the benefit of those using it. I think one of the really interesting things from the point of view of sitting outside in the research world is that this is a bit of a reframing from the way that researchers looked at questions in the health system, which is what are the research questions that are interesting that the health system should answer, or the way that the system has looked at questions, which is what are the system questions we need to know in order to be able to address them. And this is sort of a reframing of that to actually what are the research questions we need to ask, that we need to know, and what are the system questions that are interesting. So actually sort of flipping it from that sort of user-identified need to user-identified interest, and researcher-identified interest to researcher-identified need. And I think those are a slightly different way of thinking about this in a way that actually helps the system learn in both the way it needs to and the way it hasn't realized it needs to yet. And I think one of the key factors here is, as you've outlined, that system approaches are inherently messy. And I don't think that's a problem. I think we should let system approaches be messy and move towards improvement as we can. So incremental improvement is still improvement, even if it's not something that is a double-blind trial. I think we have the opportunity here to create system-level approaches that are messy in their development, but actually provide us with information and implementation approaches we've not had before. So I think that's a really interesting opportunity. And one of the other experiences from my time in the UK is the sort of slightly tweaked idea of rapid innovating health systems alongside rapid learning health systems. So I think, John, you touched on this idea that health systems have the opportunity to try new ideas, test them out, and then spread the things that work. And I think we shouldn't be afraid of doing that. I think that idea of that rapidly innovating health system has to be tied into the learning side as well. This is all incredibly timely for Ontario for a number of reasons that you've already mentioned. But I think one of those is this collaboration in Ontario that we haven't necessarily seen in the past. John, you identified the role that we've been able to play as a support unit in terms of bringing the research system together, but I think this is now expanding into all those other stakeholders who need to be engaged in that learning health system. How do we make sure that quality improvement is part of this process? How do we make sure that the delivery of health at the LIN and hospital level is included in this process? How do we ensure that the myriad of different learning health systems that occur on the smaller scales across the province can feed up into a learning system that works across the province where good ideas are spread and context dependent. I think these are things that are an opportunity for us to leverage now in terms of what's happening in Ontario. I think one of the challenges that is going to exist with this is about the robustness of learning health systems to the sorts of changes you identify, the challenges that you identify. How do we make sure that if one component is not working in the way that we expected it to, or it has to drop out for some reason, that the learning health system approach is still one that can maintain its sort of primacy and its need for the system? I think that's going to be an important question for us to be able to answer in Ontario and obviously in other jurisdictions as well. I wanted to also quickly touch on the idea that this is a big question, not just in Ontario. This is a question that is a core component of SPORE and for the Canadian Institute of Health Research. The idea of learning health systems is now written into the strategy for the Institute for Health Services and Policy Research. So that is part of their strategic goals for across Canada. It's been something that's been addressed by CHISPRA at a conference in Vancouver last year about what's happening across Canada in terms of learning health systems. I think the Choosing Wisely campaign that's been going on is a component that is incredibly useful for learning health systems on how to move out of using approaches that are not appropriate and are overused and costly for systems. I think that's a new data-driven approach that is very valuable. And I think that feeds into one of the questions that I have around how we learn from what's happening outside the province and outside our own learning health system. How do we make sure that integrates into what we're doing within a province? How do we tie that work in? So that's going to be an important component. And as you mentioned, John, I know that Tom knows whether he's on this webinar. I would hesitate to even try and touch on the work of the Alberta Strategic Clinical Networks with Tom on the line. So I will defer to him at some point if he's able to jump in. But I think they've been doing a very interesting approach in terms of taking these sort of condition-specific challenges in the Alberta system, clinical system, and saying what can we do that will allow us to learn and apply that learning across the Alberta health system within specific clinical challenges. So a different type of approach, but one that I think has been relatively effective for the types of things they've been trying to achieve. So I'm at the end of the day, I want to commend, John, the work that you and the forum have done in this, and the fact that this is really going to set the stage for how Ontario can move forward in terms of the evidence base that underpins this patient and person-centered learning health system for the province. I'll stop there.
Thanks very much, Eddie. Steve, is it okay if I jump in and answer some of those questions that were posed in the chat box?
Yeah, for sure. If you want to maybe just preface them by sharing what the question is, because not all the questions got shared with everybody.
Now I see questions from three people. So the first one was Alina, who asked about how the kind of role of creativity in addressing barriers to moving forward, especially system-wide barriers. And so I agree very much with Alina that creativity is key. So I had as one of my 7 characteristics aligning governance, financial, and delivery arrangements, but many of those arrangements are big policy decisions that at the end of the day are the purview of democratically elected politicians who have many other issues on their plate, who are being pushed in many directions by a variety of different stakeholders. And so we will always have to be creative and do what we can while we're pushing for optimal solutions. And I'll just give you one example of this from a conversation with Jean Bacon and her colleagues at the Ontario HIV Treatment Network, where Jean had done a very comprehensive piece of work with her colleagues about what some of the challenges were in moving to better use of pre-exposure prophylaxis among people at risk of HIV. And 2 of the financial arrangements that were examples of problems were payment for the drugs for people who fall between the cracks of our existing prescription drug plans, and the other was the remuneration of primary care physicians because the time needed to do the counseling and so on for pre-exposure prophylaxis often is greater than the amount of time that they're reimbursed for a visit. And so there were just very pragmatic but creative solutions, not ideal, but, a drug company willing to consider the possibility of covering people in a temporary period before they become eligible for one of our prescription drug plans. On the remuneration side, thinking about whether people could have these pre-exposure prophylaxis clinics after hours where a different fee code would be eligible. None of these are ideal. In an ideal situation, our financial arrangements would be perfectly aligned for optimal care, but they're not. And so I think Alina is exactly right that we need to label the challenges, work towards the true system-level solutions, but in the meantime, be very creative in trying to do the best we can within what currently exists. Bill and Eddie raised the question of strategic clinical networks. Again, I won't, there's people like Tom and presumably Bill who know them much better than me. If I was talking about the quality improvement infrastructure in Alberta, I would have replaced Health Quality Ontario with the strategic clinical networks. To me, they are incredibly thoughtfully designed mechanisms to, as Eddie said, try and drive improvements in particular areas. And as Bill identified in the chat box, they're very helpfully contributed to by researchers and patients and practitioners and policymakers, and that combination is very powerful. So again, different jurisdictions have different architectures in place. Strategic Clinical Networks in Alberta is a perfect example of an existing architecture that is probably already using a lot of this thinking, and if it's not and can do more, is so logically positioned to drive a lot of this. Bill also asked about whether there are examples of rapid learning systems that do a particularly good job of bridging health and social sectors, and my answer, unfortunately for the time being, is we have not found any, but if anyone on the line is aware of any, we would be very grateful if you would share them. This to us is critically important for the future. We know at a very broad level that the United Kingdom, for example, is better at the interface between health and social services than some other countries, but we don't have a lot of well-documented examples from that in other countries about how they do this. And I think, as going back to Alina's comment, however we do it in the short to medium term is going to require a lot of creativity, because aligning the governance, financial, and delivery arrangements across those very disparate systems is involved. And then Vidi asked two questions. How can the forum support the 70+ regions? So I would say that it would not be us. I think what the forum can do is identify opportunities for others to act. So one example was in interviewing an assistant deputy minister, so a top public servant in Ontario, we identified that the reporting framework for those new 70+ regions is an incredibly powerful lever. And if all we say to them from a reporting perspective is, at the end of year one, we would like you to have identified 2 or 3 areas where you are engaging in rapid learning, and report about what you've done and where you're planning to go in the future and how you're joining up existing assets and filling gaps, that would be hugely helpful. So we can identify these opportunities, but we're not the delivery mechanism. That falls to the ministry, to people in the regional health authorities, or we call them the local health integration networks, and so on. Vidi also asked, how can we work, or how did we work with leaders to start to build this culture in the context of the work that we did for Ontario? Maybe the most tangible example was, and this was again to go back to Alina's comment about the importance of being creative. Anne Hayes, one of our colleagues in the Ministry of Health, had the excellent idea that we bring together 5 or 6 assistant deputy ministers, so the kind of second from the top tier of the public service in health, and engage them in assessing the assets at the province level, identify the gaps, and see where their thinking was. And that a researcher would call it a focus group, but that ended up being hugely valuable. And 5 assistant deputy ministers walked out of the room, in my view, very charged up about the potential. And so now we have 5 advocates at the top level of the public service who understand this, see the existing assets, recognize the gaps, see the importance of coordination, and are now so well positioned to work with the Ontario Spore Support Unit and others to drive change. So that was just one very small step to actively engage them in the process of identifying assets, documenting gaps, but also getting them excited about the potential of this. And I think that one of the things in speaking to many people that people like about this is it's not a flavor of the day. This is not a slogan that will come and go with any government. This is a way of thinking that should transcend government because it has the power to, at the end of the day, do what we're trying to do, which is touch people's lives and help to make them incrementally better. So that was also a reassuring message coming out of senior leaders that this is not flavor of the day. This is something that we need to focus on and commit to over at least a decade going forward.
I'm not sure I'm going to add anything to that. I think one of the questions that came in from Ahmed Bilal, around the way that citizens and individuals can use research evidence and the ability for them to help push the agenda for a learning health system. I think that it's a really challenging place to be in terms of taking that evidence and finding the right person to send it to. I think what we want to see, and I think John would probably echo this, is that as different stakeholders become more aware of the different issues and the evidence that's available, the whole system learns. So if we had a system that didn't apply to citizens and individuals, then we would be in a problem. And I think that the Masters Health Forum's work on making citizen briefs available is really valuable in this, into saying that actually this allows you to be an active part of the system. The SPORE enterprise is trying to make it so that citizens and patients and individuals can be part of the research conversation in general and how to get into that. So I think those opportunities are becoming more prevalent. I don't think there's an obvious way to drive a learning health system as such right now.
Great, thanks, Eddie. So we had a question, John, from Ahmed Nasir about how do you do this in a system that lacks many of the data sharing tools and infrastructures required to succeed in connecting evidence to practice?
Yeah, I don't know that, I guess my view is always you start with what you've got, and, no system is perfect. I think I alluded to earlier that Ontario, as an example, is a province very rich in data about process indicators and to some extent outcomes. I do not think it's rich in experiential data, and yet that is absolutely central here. So even a relatively well-off jurisdiction that has had a lot of resources invested in data has a hugely long way to go. So I don't have any solutions beyond, I keep coming back to Alina's comment that this is about how do we creatively move from wherever we are with whatever conditions we're dealing with, populations, treatments, the system as a whole, how do we incrementally take steps forward from there? And maybe just to quickly comment on some others, I'm about to read Merrick's, I haven't read it yet, but Bill gives a great example. I'm not sure if it went out to everybody. If not, maybe Steve, you can copy it. Bill gave a great example of some recent Canadian Foundation for Health Improvement work that brought together key players from across Canada focused on primary care. That's a lovely example of in a way, something moving towards a learning collaborative, because he talks about this going forward, where people can learn across provinces or territories. So that's obviously one piece of the puzzle, and it links back to Eddie's comment that any system, even if you're focused down at the level of a single province, we also need to be learning from outside our own sector, so that offers potential there. Alina, I'm not sure what I can say about your comment about getting into the social determinant space. I agree with you that it's complex and it's messy, and your diagnosis of the challenges makes a lot of sense to me. I don't know that I have much to add, that it is messy. We need to acknowledge complexity. But again, my view is the world doesn't, get better unless we start to figure out how to move forward on two tracks simultaneously. One is how do we creatively make incremental improvements given how the system currently works? And second, how do we simultaneously fight the big battles that will move us to a much more aligned set of governance financial delivery arrangements, a much more supportive culture, a better set of distributed competencies across the system for driving rapid learning and improvement.
John, can I quickly comment on that one as well?
Yep.
Yeah, I mean, I think that in terms of complexity, I mean, I know it's an old adage and a truism to some extent, the fact that culture eats strategy for breakfast. Addressing the culture around a learning system will help to address some of those issues around complexity. Because what we'll do is we'll create a system where people want to learn and want to understand from complex points of view. I don't think we'll have everybody become experts in complexity theory. I don't think we need to. I think if we can create a system that allows people to delve into some sort of simplified framework that says these are the components that are important, you need to work out how that fits with your context, bearing in mind there's all these sorts of complex issues associated with it. I think we will make those incremental gains that we really want to move towards.
Great. And Steve, just before you wrap up, I'll just quickly comment that I think Merrick asked a very, very important question, which is, given that we want these rapid learning systems operating at multiple levels across sectors, across populations, and so on, how do you what does the rapid learning system look like knitted together at the level of a jurisdiction? I think it's such an important question. I don't have the answers. The only thing that I know is, and it was my last message, I think we need some learning collaborative that brings together the key players across all of that and figure out how those people collaborate, share lessons learned, and so on. And we need some degree of that central coordination that helps the different groups fit together, pushes them to work together when their personalities might lead them to not do that otherwise. So those were the only two practical strategies that I've been able to identify so far, but I think we need you and many other people sitting in the room to figure out what are the many other things that need to be done to make sure that the whole is greater than the sum of the parts.
I'd like to add to that very quickly. I think the role of that top level body is to bring players together, not to provide top-down guidance. And I think that's very important. I think these different contexts require different approaches, and there needs to be an acknowledgement of that, and to work out what are the best ways to actually share the information that will make each of those work best within their context and learn from each other, rather than saying this is the approach we all have to do. So I think that's the important thing, particularly for Ontario.
Great. Thanks very much, John and Eddie. I'd like to thank you both very much for joining us today for this webinar. For those of you who attended, I'd like to thank you for joining us and for the great questions as well.